All right, so how many of you celebrated Valentine's Day? Come on. Well, February is Heart Awareness Month, and it's very appropriate that we are having a presentation tonight about our hearts and how to take care of them. And I'm so pleased to be able to bring to you, to introduce to you, Dr. Michael Rochon-Duck. He is on the staff. He's an assistant professor of medicine here at UCI. He is a UCI Health cardiologist and electrophysiologist, and he specializes in the diagnosis and treatment of heart rhythm disorders. So if any of you came in with one tonight, maybe you'll know more about it when you leave. Dr. Rochon earned his medical degree at UC San Diego. I just found out he was born in Huntington Beach Hospital. He completed a residency in internal medicine and a fellowship in general cardiology at UCI Medical Center before finishing his training, with an additional fellowship in cardiac electrophysiology at Cedars-Sinai in Los Angeles. Dr. Rochon-Duck sees patients at UCI Health Cardiovascular Center in Orange, and also at the Gottschalk Medical Plaza in Irvine. He is going to talk to us tonight about Healthy Heart for Life. So please help me in welcoming Dr. Rochon-Duck.
Thank you, everybody, for coming. I want to thank you for the invitation to appear. I'm really happy with the turnout and for the ability to talk to you all. My specialty is in heart rhythm, so although the draw for the talk was Healthy Heart for Life, this is going to be focused on heart rhythm at the end of the talk during the Q&A. I'm happy to take questions about general heart health as much as I can answer. This is my first time in this library. It's such a beautiful, beautiful facility. Beautiful facility. I've always wanted to live near nice libraries. I think I might have to move to Newport Beach. So I don't have any relevant disclosures. I'm not paid by any of the companies whose products may be mentioned in this talk. And I'm going to talk today about a couple of different issues about treatments that are available now that weren't available 5 years ago or 10 years ago, and treatments that may be available within the next 5 to 10 years for problems with heart rhythm, both fast heart rhythms and slow heart rhythms. And I don't know if anybody has a connection to UC Irvine here, but this is the mascot, the anteater who says Zot. It was the 70s, I think, so that's how it was. The late 60s, you're right. I didn't know if that was there from the beginning, though. So, if anybody has a pacemaker in the audience or knows somebody with a pacemaker, you know that the pacemakers that are mostly in clinical circulation are something like this. And we'll see during this presentation that there's kind of two themes with illustrations that are put out by corporations. First is, if they show somebody's chest, it's like always improbably muscular, okay? And the other thing is, when they're looking at device sizes, it's always compared to coins. So keep that in mind when we're looking towards today's talk. But for those of you that have any experience with cardiac rhythm devices, you know that it's somewhat like this, okay? Where you have a pacemaker that's implanted here under the skin on the chest with wires that go into one of the veins and down inside the heart. There can be anywhere between 1 to 3 wires that go into the heart. And these devices can be life-saving for people that need them, right? They can prevent sudden death because of slow heart rhythms or because of fast heart rhythms. But there are a couple of problems that have appeared and been more recognized over the 50-year history of cardiac pacing. First is that the weak link in any cardiac pacing system is this. It's the lead, which are these thin wires that attach and have to be subject to every heartbeat, pushing and pulling, 60, 80 times a minute for hours, days, months, years. So over time, that's the weak point of any system. And these are not only subject to wear and tear, but also subject to getting infected and many possible complications. So one of the things that's come about in the last 5 years, and is going to continue to be developed in the next 5 to 10 years, is the leadless pacemaker. Now, This looks like a torpedo, but this, we'll see a picture next to a coin pretty soon, I think. Two on the market that are very small. These are small enough that they can fit entirely within the heart. So the battery, the circuitry that paces the heart, entirely within the heart. So with no wires to come up to the chest, no scarring on the chest that are put in through a vein, usually inserted through a vein in the leg and then put into the heart that way. I give the dimensions here. These things weigh 2 grams, which is very light, and 2 grams, yeah, they're very, very light. And the dimensions is, they're 4 centimeters long for this one. This is a little bit longer and thinner. This one's a little bit shorter and fatter, which is, 2.5 centimeters, so about an inch long, and about 1/4 of an inch thick. So these are very, very small devices that can be totally within the heart and still provide life-saving pacing to people. Oh, here's a coin image. This is wonderful. So this is one of the devices next to a nickel. We'll see how many coins we can make if we can get maybe a Sacagawea in there. So these devices are wonderful, right? But right now they're more limited in what they can do versus the traditional pacing. The traditional pacing that we saw before had up to 3 wires that go into the heart. Currently, these are only approved to be put into one chamber of the heart, which can be life-saving for pacing, but doesn't really mimic or replicate the natural pacing of the heart. So over time, the next 5 years is going to see the next development. These graphs and these recordings here are indicating something that's very new, a study that was just published last month with the next generation of one of these devices that's coming out. We're starting to implant now at UC Irvine and other advanced centers around the country, a pacemaker that still is in one chamber of the heart, but that can sense the activity of the other chamber to keep the chambers of the heart in synchrony. So this is something that's new. It's actually just on the market now, and this is the next iteration of this leadless pacing, which can provide pacing without wires with better durability, with fewer complications than the traditional implants. So that's leadless pacing, okay? And well, what's the next generation? The generation now is one device that has all the circuitry inside, doesn't really communicate with any device besides itself. The next generation beyond this, which is probably going to be in the next 3 to 5 years, which is in testing now, are devices that can communicate with each other wirelessly, using communication through the bloodstream by sending small electrical signals. You can imagine just like a radio wave, you can get a sound that's encoded on a carrier frequency. These use something that's called the principle of galvanic communication, which allows the encoding of electrical information to be sent on with very low voltage, low energy electrical waves. So this is something that is going to be coming in the next 5 years to allow communication between different chambers of the heart. So it can have, as you can imagine, not only between pacemakers in different chambers of the heart, but maybe also between wearable technology like you might see now with an Apple Watch or a Fitbit or something like that, to coordinate and to improve the care of anybody with heart rhythm problems. And just as a comparison, I'm going to have through the audience just to pass through some of the devices that we use now, okay, and then through the talk you can kind of take a look at those as they come around to see you. And if you get one, just pass them kind of to your neighbor and make their way gradually towards the back during the talk. Yeah, that'd be great. So just to take a look, and we're passing around is just a mixture. These are demo devices, that are a combination of pacemakers, leadless pacemakers, these implantable loop recorders that are rhythm recorders, all the sorts of fancy devices that we're implanting now as the field of heart rhythm is kind of exploding, and the things we're able to offer to people with different kinds of heart rhythm problems. So the vision is, using that principle of galvanic communication, like we saw on the last slide, to have 2 or more devices that can communicate with each other wirelessly, and are able to coordinate their activities. And again, the wires is always the weak point in anything that you put into the body. So the future is really, I think, going to be towards these devices that have all the self-contained logic and can communicate with each other modularly, wirelessly, and we're going to start to see that come out clinically, I think, in the next 5 years or so. So a company is testing a device like this with 2 communicating modules. Now, this is something that can be used in other scenarios too. We sometimes use the big device like this called a defibrillator, which is one of the ones that's making its way around for people that have fast heart rhythms to potentially save the life, just like you might see on a medical show where they apply the paddles to somebody and say clear and shock, and bring back heart rhythm. Defibrillators do that continuously if needed for people that are really at high risk of having fatal heart rhythms. The limitations, though, with some of these things, this is one of the newer technologies, which is totally subcutaneous, meaning nothing into the bloodstream. The defibrillator itself is here against the rib cage, and there's one wire that goes up and top over the sternum or the breastbone. But the future is having these being able to communicate also with the pacemaker that may be inserted inside the body. So with the X-ray, you're looking right through somebody's chest. So this is on the outside of the chest, and this thing here is on the inside of the heart. So this is, again, something that's in clinical testing currently to improve the function of the things we have now to make them more reliable, longer lasting, and with fewer complications over the long term. Not a human heart. Not a human heart. This is a dog heart. So we're unsure currently about what's going to need to be done with these things in the long term. It sounds great, until the battery runs out, right? Then what are you going to do? They don't have rechargeable batteries. So right now, anybody with a pacemaker, when the battery runs down, you have to get the incision opened up, pacemaker comes out, new one goes in. And well, is that going to be safe with something that's inside the heart? Just pull it out, put another one in? These things are small enough, though, and the heart is big enough that even in a dog heart, which is a bit smaller than a human heart, that you can fit up to 2 or 3 of these things next to each other, and each one lasts for 10 to 15 years. So, for people that get this, at least in midlife, it can be a good option. It may be hard to pull these things out. Just you could see here between these 2 different dogs that both had it in. This one, you can see it looks very shiny when it's implanted, right? This is just the metal, after 3 months. This side, the heart kind of overgrew the pacemaker that's in there. So I don't know how you would pull that one out, right? So the future is probably going to be when the battery runs out, hopefully they'll find a way to do away with the batteries and just power these things with the motion of the heart, which is also something really cool, is also under development. But until that comes out, hopefully before the heart fills up with too many of these things, the plan would be to implant them side by side by side. So that's kind of the leadless pacemaker story, and that's something that we're participating in at UC Irvine. And I want to talk a little bit also about kind of even more futuristic things with advanced pacemakers that mimic the heart's natural rhythm. This is something that cardiologists look at to gauge the function of the heart. And this is not animated, but the heart function, it expands as it fills with blood, and then it contracts, the pressure goes up, and then it ejects the blood, and then it relaxes. Okay, so this is a cardiac cycle that goes around and around and around. This is called a pressure volume loop. And the purpose of this slide here on the left side is to show that pacing, as we have it now, isn't really as good at making the heart go as the natural heart rhythm is. It's a poor mimic, right? It keeps people alive. It makes people able to tolerate their natural activity, but it's not the same as what nature provides. Because nature provides a very robust way of conducting electricity from one part of the heart to another that we have not been able to replicate yet. So basically, the wider that this is means the heart's able to eject more blood, it's functioning better, okay, with a stroke. When you're pacing, it's less, it's just a little bit more of a weaker squeeze, okay? And so that's why some people that have pacemakers feel better than if their heart rhythm is going 20 or 30 beats a minute, but it's not the same as if the heart rhythm was naturally conducted. Well, we're learning to be better mimics, okay? So, this is the heart's conduction system. You see an image of a heart here and then a couple of cartoons looking at this conduction system. So the heart's natural conduction system has specialized tissue that lays in the middle of the heart that takes the electricity from where the heartbeat starts up in this chamber, which is the right atrium, gathers it, and then sends the electricity down to the ventricles, which are the powerful pumping chambers of the heart. Now, this shows some branching here, and this is a very important thing. You know, this only shows the first order branching, but it branches out like the branches and twigs of a tree, to just really, really branches out over the surface of the heart. So naturally, what happens is the electricity comes in here, it gets conducted down, and then spreads out like a fan to make the whole heart contract at the same time. Pacemakers, as they are now, only stimulate one spot in the heart, so it doesn't make the heart contract at the same, all parts of the heart contract at the same time, which is why the heart doesn't work as well when it's paced as when it's naturally conducted. Now, maybe the next step, and this is something that's also in clinical practice that we're doing at UC Irvine and still in development to get better at, is pacing this part of the heart to replicate. So instead of pacing one part of the heart here, we're actually pacing this conduction system here to activate the whole heart at the same time. Okay, it's like a master switch to pace the entire heart. And with that, this is part of the implant procedure that we're looking at. A little bit technical here, but the pacing lead, you can connect here to where this vital conduction system is, stimulate it, and make the whole heart contract at the same time. And that's been shown to help people to feel better that need pacemakers, that need pacing of the ventricle, avoid the heart becoming weak because of pacing, and in some cases help reverse heart weakness that's been caused either by pacing or by other causes. These are some of the tools that we use, the tools of the trade. So we have a variety of sheaths that the leads go through and to place precisely at the spot in the heart that it needs to go. During the procedure, it's kind of fascinating to see. I didn't really put anything up here with the video for sake of time, but there's a lot of procedural videos of every aspect of medicine that's on YouTube. If you ever want to lose about 4 hours, it's a great thing. It's just search for that on YouTube. You just get into time sync. But during the procedure, we're looking at the electrograms of the electrical activity within the heart at different spots to find exactly the right spot. Right now, this is a technically very challenging procedure. Even in the best hands, it only works about 80% of the time. The rest of the time, we have to implant the more traditional pacemaker. But again, this is something that the major pacemaking companies are developing tools to make things more successful, easier to do, and that is going to increase the clinical applicability to a wider audience. And this is still new enough, right, that this was just in December of 2019 that one of the first major trials of this has been reported. And this trial is comparing this newer kind of pacing, which is called His bundle pacing, okay, to an older kind of pacing called biventricular or cardiac resynchronization therapy. And what this trial showed is that both are pretty much equivalent, okay, for reducing the bad endpoints of weakening of the heart and people being hospitalized or dying due to weakened heart muscle. So that's where we are now, okay, and that's where things are going to be in the next couple years. But beyond that, where are our challenges? Okay, conduction system pacing, this is the advanced pacing that I was talking about. It's kind of technically difficult to do with only about an 80% success rate. And the problem that we run into sometimes is there's high long-term thresholds, meaning that even if things look good at the time of the implantation, people come back in a month and it takes a lot of energy to run the pacemaker so that the battery runs out in like 3 years instead of 10 years. So that's a nasty surprise, if you come in and you find that out. And right now, the tools are there, but the actual pacemakers haven't really been updated to support this sort of thing. So you have to really hack them a little bit to pace them in a way that makes sense. And to know who's going to be the right people to get this versus just the more traditional pacemakers is something that's kind of going to be for the future. But we've talked about the His bundle, and this is going to be, I think, the next thing, which is going a little bit further down the conduction system, which may make it a little bit easier to do, to capture one of the major branches of the conduction system known as the left bundle. Again, this is not a human heart. I think this one is a sheep heart. But showing here are the different targets. You see a little bit, instead of just one spot, there's a wider array of potential targets for this kind of pacing. But even this newer kind, this left bundle branch pacing, also just reported within the last couple of months, there's issues with technically. This is like the lead tip going, instead of implanting into the muscle, going through the muscle, which is not a good thing. Not a good thing. You want it to stick but not go through. Don't want to make any holes in the heart. So that's something also that's going to have to be worked on to be more clinically applicable in the future. This again is just kind of showing the difference in position on an X-ray during a human implantation between the different spots in the heart. And then you can see here the outline of the heart shadow, and then the diaphragm is there. You can see the ribs and all these things. So very futuristic. Okay, well, we didn't get the Sacagawea, but we got the penny. Okay, we got the penny. So just for the sake of scale, that's small, right? That's small. So this is another thing that's out there now, okay, that's a leadless pacing system that's powered by ultrasound. One of the limitations of the current pacing technologies is where can you put the leads? Sometimes you're limited by the anatomy there, but this really opens up sort of new frontiers. In case you can't see it, this is scale. Oh, this is the electrode. The system is for pacing, again, new chambers of the heart that haven't been previously accessible to therapy to help people with weak heart muscles. And this is a system that, to make that this small, it's actually powered by an ultrasound generator that's also implanted under the skin. So you got a battery here, you have the pulse generator that generates ultrasound. This little thing that's about the size of a grain of rice just picks up that signal and paces the heart when it gets the signal. So I don't know, it seems sort of like Star Trek stuff. This is a trial that's underway now to assess. This is something that's been made and is approved for trial use in humans, and we're enrolling patients at UC Irvine to test something like this out. So, well, why even have any metal objects at all? Why not just make our own cells be the pacemakers that they need? Okay, so this is something that's not, this is not 5 to 10 years. This is maybe 10 to 20 years. But different approaches to programming or reprogramming the cells of the body to act as natural pacemakers without implanting anything. Just like maybe you hear about CRISPR in the news and things like that, to reprogram cells. There's different ways of doing this. You can either, implant you can basically give a virus to these cells and make them produce these channels that control the electrical activity, or reprogram their genes to make the proteins themselves, or reprogram the cells to make them believe that they're this pacemaking kind of cells, and then they'll reprogram their own genes. Anyways, there's a lot of approaches, right? And the problem with this right now is that it's being tested in small animals, in mice, and just like with any of these genetic treatments, there's limitations there with the targeting of therapy just to the heart cells, with safety, a lot of things that are being looked at, and also with the durability. These now, you can actually make a mouse have a natural pacemaker from its own cells, but the effect only lasts, I think, a couple of months now, because the immune system sort of reacts to that foreign material. So this is something that's still going to require a lot of work for the future, but maybe that is the future. It's just being able to reprogram our own bodies to have the biologic effects that are needed without introducing or implanting anything. One last topic, okay, and the prevention of sudden death. Okay, I showed earlier an image of a subcutaneous ICD, and I think there's probably a couple of those that are circulating in there. And if if you've held those, yeah, you'll know, because they're the heaviest ones. Okay, yeah, they're pretty big, right, compared to the others. And this is the latest and greatest in this technology, made by Boston Scientific, called the Emblem. Originally made by a company called Cameron Health. It was in North County, San Diego, and then developed and sold it to Boston Scientific, with the defibrillator that's here, and you could see it in the side view here, right? You can see the circuit board, and with the wire that goes up over the top of the sternum, and it acts like those emergency defibrillator paddles that you see in a medical show if something is necessary, continuously monitoring the heart rhythm and shocking the heart if necessary to prevent sudden death. But what's the problem? I mean, first is that it's big, it's heavy. It has to be bigger and heavier because it's farther away from the heart than the other transvenous traditional defibrillators that we have. So it has to be bigger to deliver a bigger energy shock. And also because everything is totally outside the heart and far from the heart, it can't provide any pacing that's sometimes necessary in the immediate period after getting a shock from the heart. Well, okay, so 5 years from now, what's it going to be? Maybe instead of going on top of the sternum, of the breastbone, we're going to be going under it. So, between the heart and the sternum, there's a little bit of space. Not very much space, a little space. Maybe enough space to fit in a lead just like this. So this is sort of the next generation that's under development with this lead that's put in with this tool. To me, it looks sort of like the sort of like fork you use to carve roast beef, but I try not to think about that when I look at this. This goes on top of the sternum here, and this part goes underneath it, and then the lead goes through the hole in this thing here to be implanted. And then the defibrillator itself goes again, like here next to the rib cage. But because the lead is closer to the heart, needs less energy, the device can be smaller, can also pace the heart. But again, this is something that's currently in development. In early testing, the first round of testing, they actually had somebody put a hole in somebody's heart with that, which is not good. Yeah, so it's been revised since then to be safer with different implant techniques. Gone back to the drawing board, and this is also something that's been refined and refined and refined, is starting to find its way out into clinical testing before wide release. And so this is just some of the technical information on this newer system, that it can detect within 16 seconds, which is good. You don't want to let it go for more than about 30 or 45 seconds. And you can shock successfully with 95% of people. So I'm going to switch gears a little bit. So that's what we have now in terms of things that we can implant or provide to people that have heart rhythm problems of either too fast or too slow, right? Either what we call bradycardia or tachycardia, and to prevent sudden death. For the rest of the talk, I'm going to talk about treatment options that are available now for one of the most common heart rhythm problems, which is atrial fibrillation. Atrial fibrillation is incredibly common. About 3 million people in the United States have that, which is about 1% of the population. And it's projected only to grow in the prevalence over the next 15 or 20 years. So if you don't know somebody with atrial fibrillation, you probably will soon. Yeah, it seems to be, it's associated with living past the age of 60, and more people are doing that, and also with some other things, yeah. So I'm going to talk first about new options for diagnosing atrial fibrillation and try to understand what it is. Our understanding now of atrial fibrillation, in general, atrial fibrillation is an irregular heart rhythm. Okay, it's irregular, it's often fast, it makes people feel short of breath, and it can also raise the risk of people having a stroke because it makes one chamber of the heart in particular go very, very fast, fast enough that it doesn't squeeze adequately and can form a clot that can cause a stroke. So our ability to understand why people go into atrial fibrillation, treatment options, and offer therapies is going to be really important. Okay? So this is some of the technology that we use now for mapping people's heart rhythm. And just to orient you, again, just a very, very muscular torso that's always used in these things. And here's a picture of one of the chambers of the heart, the left atrium, which is where atrial fibrillation starts for a lot of people. Now, this map is actually constructed from catheters that are inserted into the heart. So these catheters are put into the heart through one of the veins, then advance into one chamber of the heart, and then this transeptal means going across a wall. So this goes through one of the walls of the heart into this chamber, and then it's tracked using a combination of electricity and magnetism to know where the tip of the catheter is in like a 3D space. So you can see where the catheter is touching the wall, and that creates a map of the inside of the atrium. So you can know the shape of the atrium just from creating it with this system. Now, not only can you do that, but in heart rhythms, you can also take a timing point during any heart rhythm at any point in the space. So, just like, you can maybe imagine like a car going by you, and you're going to click a stopwatch when it goes by. You have a friend going down the way, it's going to click a stopwatch then. You have different times, and you can track the progress of something by recording different times at different points in space. For rhythms that are regular, this works really well. Like this picture, what do these colors mean? These are different points in time. Red is earlier, okay, and then it goes up to the blue is later, and then the white and the purple are out of the range it's mapped. So if you kind of follow with your eyes, going from the colors, red to orange to yellow to green to blue, you can kind of track this, okay, in the smaller area here as it comes around, and then the blue meets the red, and that's the circle of electricity going around, around, around. And in the realm of heart rhythm, this is something that we do every day, is we identify where people are having a heart rhythm problem. Like this one is an abnormal loop of electricity that's going around, probably make the heart go at about 150 or 170 beats a minute. And you can apply energy either with heat or with cold, and that's called an ablation, to alter the way that electricity is conducted within the heart. If you can break this loop, no more heart rhythm problem. Okay, so that works really well for things like this that are regular. But remember I said that atrial fibrillation is irregular, meaning it doesn't follow this nice rule of going the same path around every time. It's more like the waves at the beach. So some of the techniques have had to be changed to really understand better what's going on in atrial fibrillation. So instead of saying, assuming that something's going to be the same every time, okay, and this is looking at different iterations of the same rhythm, instead of saying every time, well, it's going to be going from here to here to here to here, from right to left, maybe sometimes it goes left to right, maybe sometimes it goes totally left to right. But to try to understand, instead of getting a single map of what's going on with every heartbeat, to get a statistical average of what's going on, to see predominantly what the direction is the goal of this new technique that's called star mapping, which is a statistical trajectory mapping. So this is something that's still under development, okay, but is rolling out into clinical practice, and it's been validated first, in these focal rhythms. We have one spot in the heart that's generating the electricity for the rest of the heart. Here you could see this spot is identified as the spot that the whole electrical activation of the heart is starting from. And so that's been compared, this new technique of the star mapping, to the more traditional technique with this local activation time mapping. This one, no chiseled torso, just a strange face just staring out at us. And this is, again, something that's been, this shows 2019, so this is also still very recent. This showing in this rhythm of atrial fibrillation, after developing first in the more simple rhythms, that this has been used to map and to treat AF, which is atrial fibrillation, with some success, better success than the existing methods. So it gives us hope, because right now with the best tools that have been on the market for 10 years, if people have had atrial fibrillation for a short time, maybe you can get rid of atrial fibrillation altogether in 60 to 70% of people. If people have been in atrial fibrillation for more than 6 months or a year, it goes down to 40 to 50%. So the success now is not that great, and we're looking for something better, because atrial fibrillation makes people feel terrible and can lead to stroke. So there's technical refinements that are going on with this technique. It used to require special catheters, now it doesn't. This is something that's coming out. So that's kind of the best of what's out there now. And this is probably the best of what's going to be out there in about 5 years. So instead of pushing out a catheter and having to touch point to point to point in the heart, this is a really cool technique, okay? This is something called dipole density mapping. If there are any electrical engineers in the audience, please talk to me and explain the math behind this, because I don't understand, but it works great, okay? So this new catheter that's been developed by a company that's also based in San Diego. It's a great area for development of biomedical technologies, as is we are here in Orange County. This catheter is really a marvel of engineering, that it has tiny little electrodes. If you see these dots on the catheter, right, it has 48 total electrodes that can measure the electrical activation, but also has 48 tiny little ultrasound probes. Okay, the same sort of things you get ultrasound like a prenatal ultrasound or ultrasound of the heart, just tiny, tiny, tiny. The 48 of these fit inside the heart along everything else. So with this technology, the ultrasound elements are used to create a map. You twirl this catheter inside the heart, and it makes a map of the inside by using the ultrasound to know how long it takes for the ultrasound to come there and back. So you make a complete map faster than you can by moving the catheter around from point to point. You just keep it in one spot and kind of twirl it around. And the wonderful thing about this is like having a very advanced antenna right in the middle of the heart. So during atrial fibrillation, in a single beat, you can understand what's going on with the activity in the heart. With the older technology, if you have to move the catheter from point to point to point to point, you can take about 10 to 15 minutes to create a map of what's going on in one chamber of the heart. With this, you can do it in a single heartbeat. So, that's something that's really, I think, one of the next advances in understanding what's going on, especially in atrial fibrillation, where things change from beat to beat, is to understand what's going on in the whole chamber at once. And what makes this possible is some very advanced mathematics, which, again, if there's any mathematicians in the audience, please come explain this to me afterwards, but uses some sort of mathematical solution by comparing how the electricity is recorded on all these different 48 electrodes to reconstruct what's going on the surface of the heart. Okay. So when you generate the recordings with this, basically, you have a spatial voltage field, which is generated by electricity on the surface of the heart. It's picked up by the electrodes on that array that I showed in the previous one, and reconstructed to show what's going on the surface of the heart. And this is the dipole density. When you're using it, this is how it looks. Okay, it generates, again, an activation time, showing the local activation at any point from a focal, where you can see there's like a little dot, and it seems to be like bigger and bigger circles around it, right, of different colors. Or different activation patterns, like this is a rotational, where the colors kind of stack up against each other, not spreading like it was here. Then other things we call irregular activity, where the activity seems to speed up and slow down or pivot around in sort of like a spiraling motion. So we're coming to understand a little bit more about the mechanisms of atrial fibrillation, and from there can develop better treatment options, better ablation options to treat atrial fibrillation, to improve from what we have now, which again is like 40 to 50%. So that's the understanding. And what about the treatment? So ablation now, which is something that I do, and at UC Irvine we offer ablation for pretty much every heart rhythm problem that involves a fast heart rhythm. Ablation is done with either heat or cold, right? So you have a radio frequency catheter, which actually works about the same as the old style of light bulb, right? Where you flip a switch and there's a filament, okay, that you run electricity through. What happens? It generates heat, right? So the radio frequency catheters work in the same way. You pass electricity through it, and it generates heat in the tissue that it touches. But the problem is, wherever you generate heat, that heat has to go somewhere. So you want to heat up just one small area of the heart tissue, but you can never just heat up one small area of the heart tissue. And on the outside of the heart, there's a whole bunch of things that you don't want to heat up. Okay, there's the esophagus is right there. There's lung tissue. There's nerves. There's the blood vessels that run on the outside of the heart. And if you heat up any of those things too much, then you're going to have problems, right? You're going to damage things you don't want to damage, and then lead to complications for the people that you're treating. There's other energy sources that are used in ablation. One of them is cold, right? Cryoablation, which uses liquid nitrogen through a catheter that's advanced. You put the catheter where you want it. You put the liquid nitrogen through. It freezes it. It reminds me a little bit of a Christmas story, like sticking the tongue to the telephone pole. It sticks, and it freezes the tissue that it touches. But again, when you freeze it, the stuff on the outside can also get frozen. So we tend to like to use this cryoablation, which is the cold ablation for atrial fibrillation, but it can also damage the surrounding tissues. So we're always on the lookout for something better. Lasers have been tried, which sounds exciting, but it hasn't really penetrated too much. This is something that's different and it's new. And this is something that's still in development, but in 5 or 10 years, you're going to see this as going to be the dominant way that ablation is done. It's called cardiac electroporation. Electro, like electricity, pores, like making pores or holes, right? And this is something actually that's been adapted and used from use in cancer treatments. Electroporation is something that's used in some cancer treatments to temporarily poke holes in some cell membranes so the chemotherapy drugs can get in. Okay, it's just like poking little holes so the drugs can get in, the holes heal up. That's temporary electroporation, or you can do permanent electroporation that actually damages the cells permanently. And again, this uses electricity that's done with a catheter, creates a local electrical field, and the way that the electricity is applied is still being tested through different things, using direct current, AC, or pulsed DC current. But the interesting thing is that the way that this affects the tissues of the body is dependent on the tissue. It seems to affect cardiac muscle, in certain frequencies and energy cycles more so than the tissues that surrounds it, which is like the holy grail, right? So what I said earlier is that we're afraid when we ablate of using the heat or the cold, because the heat and the cold can damage everything that's around, the lungs, the esophagus, the blood vessels. This technology, it has the promise of being selective for the heart muscle, so damaging the heart muscle at lower energies than it takes to damage the tissues surrounding. So you can ablate a little bit more safely, a little bit more effectively. And interestingly, I mentioned the radio frequency and the cold, but even before that, the first ablations, which some which were done here on the West Coast in San Francisco at UCSF, use a technique called DC fulguration, which basically you put some DC current through the end of a catheter and made a little bit of the heart tissue explode. It was like throwing a little grenade into the tissue, which was effective at damaging the heart tissue, but you can imagine that damaged a whole lot of other things too. But this is a refinement of this over the course of 40 years later. These are some tissue samples looking at different tissues after having this sort of procedure done with the electroporation. And we're looking here at what looks like healthy tissue, the pink, okay? And we're looking at the vessels that are in the middle here that are spared from damage from the electroporation. This is an esophagus that's been kind of splayed open to show that there's very minimal damage to the esophagus when doing the ablation from the heart. There are a couple different companies that are developing this technology, and they have different catheters that look different shapes. This one's quite pretty, I think. It looks like a little flower, a little daisy. And so you can see this is kind of how it is. It's just put up into the heart to the target, and then the therapy is delivered. So this is, so far, it's really promising because it's faster, it's safer, and it's more effective than the treatments we have now, which is 3 things you don't often see together. So this one's not as pretty, but it's a different catheter shape. It's used on the outside of the heart instead of on the inside. You can see just encircling part of the heart we want to do the ablation, like a lasso. You apply the energy, and then that's it for the ablation. So the effects on the heart have been very, very good. They've been very reproducible, giving the damage to the parts of the heart that you want to damage and not damaging the parts that you don't want to damage. Mostly the testing on this so far has been done in some centers in New York and Philadelphia, but we're looking forward to starting to test that out here at UC Irvine as well. And this is the early days. So even finding out how to deliver that energy with different ways of running the electricity through the catheter, that's still all under development. Whether to cycle the electricity with different frequencies, monophasic, biphasic with different frequencies. is still under investigation. Again, this is from 2019, so just last year was this reported on. But it has the ability with this pulse field ablation, which is the other name for electroporation, to damage the cardiac tissue while relatively sparing the stuff that's around it. Thank everybody for coming. I hope you learned something today. I'll be around, okay? But I just want to attend, make sure safety first. Yeah, thank you for coming.